you. Thank you, Lindsay. Thank you, Neil. And thank you, all the opening panelists. I want to make sure we get to all of our partnership panel here, and that's, we just want to welcome them all to the discussion. Let me kick it off, please, by turning to Danjuma, who is the former president of the World Hepatitis Alliance and has a great deal of experience in working with hepatitis prevention, linkage to care and treatment in Nigeria. So Danjuma, let me just turn it over to you in particular to comment on the role of civil society in the research we're talking about today. Thank you.
All right, thank you, John, and thanks to the Global Coalition for inviting me and for having us on this very important panel. It was quite interesting for us to be part of the discussion last year. I'll speak from two perspectives. One, as someone that is living with hepatitis B in particular, and also from the civil society perspective. And John, across most low middle income countries, the first thing a patient goes to the hospital is the person is going to the hospital with the hope of finding care, with the hope of finding solution, right? And most often, the patients in most of our facilities, you either leave confused or you leave with more questions unanswered because of lack of proper timing, lack of education. The clinicians will not have enough time to educate the patient, multiple diagnoses, investing on multiple tests that the patient needs to run. And you go to different healthcare workers, they give you different interpretations, different perspective to the condition you have. So these are issues that I think sometimes constitute a problem to patients accessing care. So the lack of awareness and lack of education is a very big barrier that needs to be addressed. And these are things that where the civil society can come in, John, and where because we are there at the community, the patient spends less than maybe 1 hour, less than 5 minutes with the clinician and goes back to the community. And most often the patients are left to their own fate to go and search for information, and most often go to the wrong sources to get information. And that is why civil society are there to break down those barriers, the cultural barriers, religious barriers, and also some aspect of lack of knowledge and awareness. Sorry, I have to switch off my video because I have lighting problem here. So some cultural barriers or myths and misconceptions, that is a very crucial role civil society play, because through peer support, through peer navigation, through peer information, is very important, because as a community person, we build trust with the community. We are in the community, and we, especially as people with lived experience, are there as patients. So we share our story. I remember when I shared my story, John, it was a stimulus for many patients to break down stigma about hepatitis. So people feel more confident when they engage with peers and they speak with peers. So civil society will play a crucial role in breaking down some of the structural barriers that limit patients from accessing care, and also in some aspect of education and awareness, and even in the demand creation. I remember Jibril mentioned something about services are there, but there's no demand from the community. So we play a very crucial, important role in demand creation, in creating the need for people to go for the testing, and also helping to break down some of those structural barriers that exist in making patients seek for services. So, but I think it's important that maybe simplification of diagnosis, John, will be a very big way to really allay the fears of patients. You discover you go to a hospital facility, you're given 10, 15 forms, that different diagnostic forms, and the patient is more confused than anybody as to what needs to be done. So simplified testing, simplified algorithm will be a very good way to allay the fears of patients and motivate patients, all right, to seek care. And then even early treatment sometimes also helps. As a hepatitis B patient, I know the several times that I've been asked to come back, even with my knowledge, with my background in virology, come back after 6 months, come back after 1 year. You don't need treatment today, come back after this. So, and I think the guidelines then that never place more people on treatment kind of discourage many people from going back to the hospital. So many patients who prefer to access the herbal traditional medicines, who promises the wonder cure, than going back to the hospital that they will tell you, come back after 1 year. You leave the doctor, you go to the laboratory scientist tells you something different. You meet the nurse, they give you. So even in the healthcare system, the lack of coordination of information also is a challenge that I think needs to be streamlined. So training of healthcare workers would definitely help. And cultural barriers, even in hospitals, You know, someone goes and then meets people who cannot speak the language of the patient, who doesn't understand the simplified language of the patient. These are serious barriers that I think, if addressed, would definitely improve patients' access to care and would definitely improve the treatment outcomes for patients. Thank you.
Thank you so much. And what I really hear, just the importance of getting civil society organizations engaged at the outset, throughout, make it really become a research partner, and then really help with the dissemination of the findings to increase acceptance of improvements in care and treatment. Thank you. Let me turn it over to my colleague, Marc Ghany from the U.S. National Institutes of Health. Marc has many years of experience in studies of hepatitis B, and I just wanted to get his perspectives, on the roadmap, and how it aligns with some, the robust research going on around functional cures, and just to see how we can begin to perhaps incorporate sites in low and middle income countries in both of those research activities, both with the current treatments as targets, as well as the hopeful new treatments coming up. Marc?
Sorry, let me just mute myself there. I don't think I can get my video back on. Hopefully folks can hear me. First,
Clear.
Yep, great. So first, John, thank you for inviting me to participate on this important webinar. And I'd like to offer my congratulations to the coalition on developing, which I think is a really brilliant research roadmap. I think it's very timely and really addresses what we need to do if we're going to make any inroads into lowering the burden of disease due to hepatitis B, particularly in low and middle income countries. And I think it actually nicely aligns with the National Viral Hepatitis Elimination Plan here in the US, as well as with the NIDDK Strategic Research Plan for reducing the burden of disease here in the US. From an NIH perspective, I think the research priorities are well thought out. And as you've heard from other speakers here on this webinar earlier, I think it's really hard to say which priority is more important. In terms of transmission, obviously priority 2 is the most important, because if we don't break the cycle of transmission, particularly mother to infant transmission, we're not going to make any inroads into reducing the burden of hepatitis B. And similarly, priority 4, which addresses the burden of morbidity and mortality associated with disease in persons who have chronic infection, if we don't address that crucial part of the roadmap, we're not going to reduce the burden of health aspects related to hepatitis B. So I think they're all equally important, and we can't achieve any of the goals of the roadmap, I would say, without adequate and appropriate diagnostic testing. So I think the roadmap is each of the parts have to be addressed, I would say, in parallel rather than in sequence. Now, if I could speak maybe from the NIH perspective, what is it that we can do to try to help facilitate implementation of this roadmap? The NIH is currently conducting studies to look at biomarkers in terms of predicting outcome of disease, as well as for early diagnosis of liver cancer. We're also conducting clinical studies with the goal of developing finite therapies that can achieve functional cure or sustained loss and maintain suppression of viral replication, which is what we know we need to achieve in order to reduce the adverse outcomes of the infection. And importantly, I think this research can help inform how these new treatments might be applied to low and middle income countries. You've heard about the challenges that are being faced, even when we have a simple cure, such as nucleotide analogs, which is just a pill a day. Some of the more novel treatments that are being developed are quite complex. And we have to figure out a way on how we can translate these complicated regimens, simplify them so that they can be applied to areas of the world where the true burden of disease exists in these low and middle income countries, which accounts for almost 9 out of 10 infections related to hepatitis B. But I see the NIH playing also a broader role. That is really in conducting and supporting basic virological and immunological research so that we can better understand the disease pathogenesis and the mechanisms of functional cure. And I think this research is really very critical to developing new therapies. Currently, many of the regimens that we're studying right now are largely empirical because we lack the fundamental understanding of what's required for the virological and immunological basis to achieve functional cure. So I think these are important. It's important to continue to conduct this very crucial basic research. And then I think we can also lend expertise to low and middle income countries, because I think they're very capable of doing the research at the ground level, but we can provide additional expertise to try to understand what are some of the basis for the different presentations of hepatitis B, what causes cancer, what causes disease progression, what is the role of genotypes, particularly in cancer. There's been some suggestion that genotype A1 might be more carcinogenic, particularly in sub-Saharan Africa, and also the role of environmental factors such as aflatoxin, alcohol, etc. So I think where I see the NIH, just to end, is really in partnering with the researchers to help them try to answer these questions that are critical really for achieving the goals of the roadmap. And again, wanted to offer my congratulations, what I think is a really well thought out program. So thank you, John.
Mark, thank you for those comments. You're spot on. You answered one of the questions that came up in the chat regarding the importance of looking at differences, by geography, whether it be by genotype or cofactors that can accelerate the progression of hepatitis B, liver disease, and look forward to NIH being a partner in the rollout of this roadmap. Let me turn it now over to my colleague Rabson Kachala from Malawi, who is responsible for a variety of different aspects of hepatitis B prevention, care, and treatment. And they've been doing some work in strategic planning regarding the next steps in those areas. And just want to get Rabson to comment on which research questions really come to top of mind as we're talking about the research roadmap today and the discussions you're having about next steps and what would be helpful in Malawi. Rabson?
Yeah, thank you, Prof. And all the team. Greetings from Malawi. Congratulations for coming up with this roadmap, which Malawi, as one of the low-income country who actually benefit a lot. Indeed, it's in line with the Malawi government health sector strategic plan 3, taking us 2023 to 2030. For health research, it's in line, especially coordinating the partners in financing the health research. For us, our policy is 2% of our budget from 2023 up to 2030 is 2% of our budget. It's reserved for health research. We have a director within the ministry responsible for that, but also the Public Health Institute of Malawi. We have a directorate of a component of research, which they're working with us. So I'm happy to report that we are trying to follow up on this Malawi commitment, but also our partners working in Malawi it's the policy is 5% to reserve for financing, as Lindsay said, within the roadmap. We, apart from the activities, we also need to have the cost estimates. So indeed, the coordinating partners, it's very important. As my colleague Adda has already said, the challenge in Africa, like my colleague in Nigeria, Gambia, said it nicely well about the challenges here. So Malawi, we are actually having more or less the same challenge, but we are looking forward to this roadmap so that we build on the health research from the public institutions, the private and academic, to make sure that we have the health research adding to the new information as regards to the operation of the programming the Hepatitis B in Malawi. Also, the evidence-based informed policies by 2030, when we'll be adding the having a new HSSP, that is Health Sector Strategic Plan, the new one. We need the information. We really need to have new information about that, but also monitoring these guidelines which we are using for the Hepatitis B. We have the new guidelines we are using up 2030, according to WHO and your coalition. You have been supporting us. We are working to make sure that we monitor, keep on monitoring it and evaluate it. So all that we need new information, but also chasing and accessibility of data across systems, and to be strengthened to enable them be used. Like my colleague Adda has already said, the challenge the clients they might come, they should not be disappointed. We should be able having knowing that we should expect it to come such amount of clients. We should actually have such amount of test kits so that everyone should be tested. All that in heavy systems should be in place so that we should not disappoint our clients. They should be tested accordingly. So as the Malawi government, I'm happy to report that we are working with the responsible directorate in working to come up with all the necessary areas to continue with this roadmap. We'll make use of it. So maybe I can give an example for what Gambia, my colleague, presented about triple elimination, for instance.
Yeah. Very, Rabson, I'm so sorry to interrupt, but very quickly, I know that we're right up on time, but please proceed, but briefly, please. Thank you.
Okay, thank you. Yeah, so it's indeed we really need to through what Marc has already said as well, and also Dr. Marc said, for instance, apart from that, the issue of we have the cancer registry, ADEX. We have been working also with ADEX to make sure that apart from the other causes of liver cancer, we have also to know the Hepatitis B in Malawi. We did the initial test with the registry data. We showed about 75% Hepatitis B is causing liver cancer in Malawi. That was around 2018 up to 2020, but now we didn't need to follow it up. So all this operational research, we didn't need, as Dr. Marc has said, we didn't need Malawi to follow it up on all that as well. So we have equally Malawi blood transfusion service where we do the Hepatitis B testing. All that we didn't need to keep on following to make sure that we follow all those tests. So operational research on all this, it's very important, John. I think.
Thank you, Rabson. I just want to interject quickly. There's a question regarding specifically about Malawi, which is, what do you see as the biggest challenge to implementing hepatitis B birth dose in Malawi?
Okay, as of now, they might have approved that we can start using that as universal, but the main challenge is financial challenge, which but I'm happy to report that our minister has already given the letter to Gavi so that they can actually assist us. So everything has been done in place in terms of quantification and everything. So the main challenge, it's really the resources. So we are appealing to the global village to assist Malawi. On our part, we are doing all it can, but everything is ready to start birth dose. It's only the financial gap.
Thank you so much. Again, Rabson, spot on comments. Let me turn it over to Wendy Spearman, who is from South Africa, has years of experience working with hepatitis B in South Africa, as well as being very involved as being the chair of the committee to help WHO, who we'll be hearing from in just a moment, update treatment guidelines. Wendy, you also run an ECHO program to seek to educate non-specialists for hepatitis B care. As we think about research and your engagement with primary care and other type of non-special liver specialist providers, what comes to mind for you as really important research questions? Thank you.
So, I think the real problem is, despite this burden of liver disease associated with viral hepatitis, and particularly hepatitis B, one of the problems is not recognized, and I think has a major impact. It's acquired from mother to child, early childhood, but you see the devastating effects in early adulthood. And patients really present to you with established cirrhosis, multifocal HCC, and there's really often nothing that one can do for them. And so this burden of disease is really not recognized. And I think it relates to the really failure to understand the natural history of disease, how it presents, and education. And we really need to raise public awareness around the disease, but also healthcare workers. And if we're going to really make an impact, as we've heard from a number of the speakers, we need to decentralize this to primary healthcare. And if you look within Africa, you have some excellent centers of clinical research, clinic and basic science research, but really the burden of disease is actually often in the rural areas, where the access to care is very limited. And so, this is where Project ECHO has really made a profound effect sort of globally across many, many disease disciplines. And I think the real beauty of Project ECHO is you can actually adapt it to what you require. So you can do it at primary healthcare level, you can do it secondary, you can do it at highly tertiary and quaternary care. But I think if we're going to make any inroads, we need to actually improve the outreach in terms of primary healthcare, community healthcare levels, and importantly, midwives. I think we tend to forget about the midwives. We're often that first interaction. And so the benefit of the Project ECHO is that you have this very short didactic lecture, and you can develop a curriculum of training across over a period of 6 months, or you can actually address your didactic lectures to the underlying problem that's been presented. And then one of the things is that the community actually present cases that they have difficulty with. And it's actually the benefit is that it's actually a collegial approach, that we all learn from one another and we learn how to adapt to what is available. So we know that diagnostics are very difficult. They're often quite expensive. We don't have access necessarily to DNA, to genotyping, but I think we're able to work together to actually really encourage the diagnosis, linkage to care, and importantly, promote the adherence. And I think Philippa will actually come in and show how the new WHO guidelines are going to actually improve that access to care. But I think we need to look at these community outreach programs, and importantly, which has been highlighted by Danjuma, is really involving the patients living with hepatitis B, involving the community. How do they see their needs, and addressing that? And I think unless we actually raise that awareness at primary healthcare level, at public health officials level, to the same sort of heights that HIV, malaria have been very effectively taught across Africa, we're really not going to make a difference, I think. So we really need to take it down to the grassroots level. And then I think in terms of that sort of birth dose vaccine, we need to learn from we mustn't reinvent the wheel. So if we look at the Western Pacific region, we look at China, the highly effective use of community lay workers to actually identify mothers who are pregnant, identify those who require the vaccine outside the health facilities. And we need to learn from that. And I think, we often we underestimate the simple sort of research programs that we can actually run by doing simple surveys and actually finding out what are the barriers, what are the challenges, how have actually people overcome it, and then implementing that. And then really, I think the other important thing would be to strengthen the established networks like HepSanet, like Philippa, like the Hepatobiliary Pancreatic Cancer Consortium, which have been highly effective. And the reason they've been effective, they've actually identified centers of excellence across Africa, really reflecting different regions with different problems and different manifestations. And as a result of that, we're able to have really very good research coming out of that. I mean, if we look at the HepSanet, we've really looked at what is more an appropriate APRI score for hepatitis B in terms of addressing cirrhosis. So there's a lot of clinical data out there, and I think, and there are a lot of excellent clinicians, researchers, but we need to come together more as a group and work collegial and actually have support for that, because that requires setting up data systems, setting up the IT, actually support with statistical analysis.
So much, Wendy, that we touched on a lot of important points regarding just getting the outreach, the testing, linkage to care, the adherence to care and treatment. Also sort of forming a network of networks of how can you get the data management systems out there so you can really begin to share data from these treatment sites to really see what's going on now and what new interventions are implemented. I'm going to turn it over to Philippa now, who's been leading treatment guideline development at WHO for a number of years. We just had a question in the chat about the research to engage to implement the current policies for hepatitis B treatment, notwithstanding the upcoming and new policies. And so just wanted to, Philippa, to give your perspectives from seeking to implement the current policies and then really doing an extensive review and engagement with partners around the world for the new treatment policies. What research priorities come to mind for you as they're presented in the roadmap? Thank you.
Well, thanks, John. I think, first of all, it's helpful to just clarify WHO's role in the kind of research agenda setting. One of its mandates as a normative agent for setting global and regional policy, as a byproduct of that, we develop research agendas, identify research gaps. And we're not research implementers. We generally work with partners to deliver research. Sometimes we do lead in research. And we have a formal process for highlighting research gaps and research priority setting. Although I would say with all the value assessment frameworks and multiple criteria decision analysis, but we largely do this in our department as a byproduct of guidelines development processes. So those are the critical events where we have all the right people in the meeting, the stakeholders, the clinicians, researchers, implementing partners, the Ministry of Health, civil society. And that is where, as we work systematically through each topic, we identify the research gaps. And I think it was very opportune that the task force was also sort of at the right time developing their research priorities. And so it's been a real opportunity to align forces. I think it's fair to say the guidelines meetings are very busy, and the discussion of the research gaps often doesn't get the time it deserves. So it's difficult to actually separate the research priorities from 2015 to now. Some of them have been migrated into the current research gaps. And I think that was from 10 years ago of what the hepatitis B research priorities were. I think what is probably useful to do is to flag how we can help the researchers, and also the key topics where we align, and some of those that have not been profiled in the task force initiative. So for us, it's not just more research, we're really wanting high quality research that's focused on the priority issues. I think, as others have said, really facilitating the forming of consortia with a good mix of the frontline clinicians, with those with strong statistical methodological skills, protocol development and governance. And there are many good examples of those consortium in HIV, and that's growing for hepatitis B, and HepSanet's been a great recent initiative. getting the funding agencies on board, sharing these priorities with the major research funders to ensure they're captured in their own research priorities and grant calls, highlighting the priorities at different conferences to prompt dialogue, and supporting training and implementation research. I think in terms of the synergies, for me, the service delivery is really key. And what we're needing is the methodologically rigorous studies. And so I think, as Alex identified, that really we want studies that are fully capturing the interventions, the service delivery models, and capturing outcomes across the whole continuum of care. And it's not just different interventions, but different packages of interventions that's been described. I think something that's probably missing from the discussion, people have talked about different models of decentralization and task sharing. That's straightforward. But to facilitate that, we need a range of differentiated assessment, care, and referral strategies that relates to both decentralization and task sharing. And then I think we really need to do, and I haven't heard this mentioned, the evaluation of interventions already well established for the use in HIV care. Those strategies to promote and sustain adherence to long-term antivirals, and strategies to promote retention in care and re-engage those disengaged from care. Good cost effectiveness studies as an integral part of that. And then pretty much the same with the PMTCT, and particularly the new recommendations on antiviral prophylaxis for all. What are the practical implications of this? And in research terms, that means evaluating the feasibility, the effectiveness, and the cost effectiveness of more comprehensive peripartum antiviral prophylaxis strategies. Looking at studies of adherence in pregnant women, follow-up studies to look at some of the potential harms of those discontinuing antiviral therapy postpartum. And I think the areas that are probably less of a focus in the task force that is on the treatment studies, really long-term studies to show the overall impact and effectiveness of expanding treatment eligibility on all the clinical outcomes, looking at long-term data on the safety, both bone mineral density, renal function, and potentially some RCTs of antiviral looking at the treatment impact of those with a low viral load. We need more data on adolescents and children. And I think, as Marc has flagged, clearly the public health angle to the curative antiviral strategies, and also looking at some of the innovations on long-acting and injectables, although those would be the lesser priorities. So I think that's just a quick gallop through the positioning of WHO, where we feel we can support the frontline researchers, and how we align on some of those research priorities. Thanks so much.
Thank you so much, Philippa. Thank you all to all the all the panelists.